Good evening. My name is Tim Gibbs, Director of Delaware Health Force. Welcome to the third session of Delaware Mini Medical School, Spring 2025, which we're doing in partnership with Christiana Care. Here are our social media tags. And as always, you can go to delawareminimed.org to see upcoming classes, what we're going to be talking about, and also usually after about 24 hours, we post the previous class and the PDFs that came along with the class. So if you need to do a makeup, you will coordinate with Nicole Sabine. If you have any problems with Zoom, you can go to our streaming channel here. Nicole will be dropping the direct link to this evening's stream into the chat. Just a reminder to folks that this is a webinar, not a meeting, so we don't see you, you don't see each other. The one way that you interact with us is with the Q&A, and that's where you can ask questions, whether they're clinical or housekeeping. Just remember, don't ask any questions of a personal diagnostic nature. For the adults who are joining us, there's no continuing education credit from this series, whether it's CME or CE. You're doing this simply to increase your own knowledge. And for this evening's presentation, understanding the yellow man, I understand. So I'm very interested to hear what we're going to learn. Our partners for this series are the Sussex County Health Coalition and Christiana Care. And I believe that is that. We'll fly on through this. So yes, the case of the yellowing man. And to introduce this evening's speaker, I'm going to introduce my colleague, Dr. Tabassum Salam. Tabassum is a board-certified internal medicine physician with 20 years of multifaceted experience in healthcare. She is the Chief Learning Officer at Christiana Care, works in multi-professional academic affairs team, delivering learning and professional development to physicians and other clinicians at all stages of their education. And hopefully that is many of you, our future doctors and nurses and public health colleagues. She received her medical degree from the University of Pennsylvania Perelman School of Medicine and her MBA from the Wharton School at the University of Pennsylvania. Over to you, Dr. Salam.
Good evening, everybody. Thank you for that warm welcome. And on behalf of all of us at Christiana Care, it is such a pleasure to be able to partner with you on this amazing Delaware Mini Medical School series. Tonight, I have the extra special honor of introducing my friend and colleague, Dr. Bridget Peters. She's a family medicine physician and core faculty member at Christiana Care, mostly centered in Wilmington, Delaware, at our Wilmington campus. In addition to her clinical duties, she also serves as chair of the Graduate Medical Education Diversity and Inclusion Committee, and she's the clinical lead for Wilmington Family Medicine. She focuses on improving clinical care and advancing diversity in the medical field. She is a native of Charleston, South Carolina, and she graduated from Spelman College. And after that, she completed her master's in kinesiology at Auburn University. She then made the decision to further pursue her studies of kinesiology and went on to earn a PhD in the cardioprotection lab, also at Auburn University. She then also went on to medical school at Edward Via College of Osteopathic Medicine and pursued her residency at Prisma Health in South Carolina. It's a great joy to have you join us, Bridget. And, we've got a lot of aspiring healthcare professionals in this audience, and they're always very curious about how each of us got to where we got to be. So, Bridget, first of all, tell us about your educational journey and what led you to the different fields and the multiple degrees you have earned over time. Tell us what kinesiology is. Tell us what you did in the cardioprotection lab and how all of this eventually led you to become a family medicine doctor.
Yes, thank you so much for that wonderful introduction. I told Tabassum when I joined, I said, oh my gosh, I'm shy and you know that, but I'm not really. So just joking. So thank you so much for everyone for having me. So as Tabassum mentioned, I started at Spelman, majored in biology, always knew that always knew that physician was one of my end goals. However, throughout my journey, I was very open. And so if, I think on some of these talks, we always say, what is your one advice? And I would always say to be open with the journey. So I was very open to mentorship. And so throughout, I knew I wanted to do prevention. So I was about to graduate and I said, I really would like to do more before going to med school. And with that more, one of the best advice I received at that time was, hey, I think you would enjoy research and doing preventative research. I also had never heard of kinesiology, which means the study of movement. And so I said, man, I thought that was just athletic trainers or people going into physical therapy, biomechanics. Had no idea that it actually incorporated also science benchtop research. So I used pipettes, I used mice and rat models. And what we actually did was we used an exercise treadmill or wheel, and we would exercise the rats and mice to then induce a heart attack. And from that, we saw what molecules in their body would increase that would be protective. So when they go through their reperfusion phase, or when we reverse the heart attack, which we would do in a human, to then what would be protective from that heart attack. So it was very, very cool. And then how that translated into me then saying, I still want to go to medicine, because from that, we would publish papers telling people, well, if you exercise this much, or if you do this amount of physical activity, it translated to me into education to patients and preventative medicine. So it tied into me doing the osteopathic route as well, because I felt like it was very holistic. And I was able to do more lifestyle medicine. And then that also led into why I chose family medicine, because I get to do it all. So it is from the child to the adult, and I get to tell someone, well, if you purchase food and cook for your whole family, now you're even, mitigating or stopping childhood obesity, but also helping your own diabetes, for an example. And so that is, in a nutshell, kind of what led to this path and me choosing all of those different steps in my career.
I love it. I think it's going to inspire several people in the audience to remember there's more than one way to get to the clinical professional role that you want to get to. And I love what you said about being open-minded about learning about all the different ways you can educate yourself, learn new skills, and fulfill your passions. And eventually, if your hope is to be in a role where you can take care of people, there's more than one way to be able to find that fulfillment in your career. Well, I'm going to turn things over to you. You have an amazing presentation lined up. We can't wait to hear all about it. So I'll be right here listening along with everybody else. Take it away.
Thank you. So, in my true nature, I would like to start off with some questions. I know I can't see everyone, but I know that we can get some crowd participation. And so, I would like to start off with some poll questions. These are not at all science or medical related. They're just to say that we are all one family here learning together, because I can learn from you all in many ways. So if we can pull up the poll questions at this time so we can participate, that would be awesome.
Yes. Which one would you like to do first?
Let's do the seasons. It's nice weather
Okay.
outside. Let's see what everyone says.
So it is launched. You guys should be getting a pop-up.
So the first question is, what is your favorite season? There is no right answer, but I do say that I have a favorite. So you should all choose your favorite.
So right now we have 36 of people, 35 saying summer,
Okay.
9 fall. Winter is 13%, and spring is 23%. So it looks like a little bit over third say summer.
Summer. So that is an awesome choice. Tabassum introduced me and said, I am from Charleston, South Carolina. And so I would say if I had to choose, summer and spring are two of my favorites, because I am from such a coastal area and we get to go to the beach in those times. However, one of the things that attracted me to Delaware was that you guys have beaches too. So I get to still fulfill that one little piece of Southern nature in myself. So, okay, thanks, guys. All right, so we have one more starting question. Again, nothing to do with medicine, but we are going to pull it up. All right, so when you're thinking about food, are you a more sweet or savory person?
Oh, these are coming in fast.
Oh, so we like food. I do too, guys.
So it's larger on the savory side. We have 60% at savory, or 61, and 39 is sweet.
Okay. I too would probably eat more savory things than sweet. So the sweets are always delicious. I just actually came from, we have these practice retreats for my office. And so we had a nice event and we had beignets. So I would say that's a more savory sweet treat. So it was a little of both. So thank you everyone for participating. I'm going to go ahead and share my screen so we can get started because I do want you guys to be able to ask several questions for this presentation. Okay, so I'm going to go ahead and start. All right, can everyone see the screen?
We can.
All right. Okay, so Tabasa mentioned that I am a family medicine physician. And a little bit about that is I get to work in the outpatient and the inpatient world. We mentioned that I am a core faculty member. And so what that means is I also get to work an inpatient with our residents. Residents are learners that are already finished with medical school, but they are now training to be physicians. We actually do get some psych residents on our team. We get some people who are going into radiology, but mostly we have family medicine residents. So I get to round in the inpatient world. So that's when I get to see the really, really cool cases. Outpatient I do too, but usually our wonderful hospitalists have already discovered what's wrong with them and now we're just treating them. So this was a cool case because he came in and it was unknown. So we got to go through the good and bad news with him. So this is the case of the yellowing man, and we're uncovering the etiology of acute painless jaundice. So again, that's who I am. All right, so this was a 72-year-old male. He was very pleasant, morbid obese, hyperlipidemia. He had some hypertension, which is high blood pressure, but all of those things were controlled. So for all intents and purposes, this gentleman, although he had chronic conditions, he was going to his primary care doctor, we're going to say, he was taking his meds, he was doing all the things that I would check off the box and say he is very, very healthy, considering his chronic conditions. He had 1 week of worsening fatigue or sleepiness. So he said, I just felt exhausted. He was a very active man. He was retired. The story is he had family by bedside, very loved, and he would pick his like 3-year-old granddaughter up after school, after daycare, and he was the one that watches her. But that week he just was like, I can't keep up. Like I just can't take care of her. I just really can't keep up with my 3-year-old granddaughter. So the day that he came into the hospital, he actually did end up trying to go pick her up. And his daughter looked at him and said, I don't think this is just a tan. You look really yellow. And so he actually didn't really notice it, but his kids and family members noticed it. At the time that he came in, he said he had no pain in his belly. He had no blood in his stools. He had no chest pain, just this very fatigued state, and also just the yellowing of his skin. So I don't know if any of you have ever been to the emergency room. When you come, there's a lot of tests that get done. So when he came to the hospital, he had a heart monitor set up. They wanted to do EKGs, which was a tracing of his heart, and that was normal. They did a lot of blood work, which is a comprehensive metabolic panel. So it looks at all of your electrolytes like potassium. It looks at your chloride and carbon dioxide in your blood, and also your liver function. So they did see that that was elevated. And then some of the history that they took from him, They asked him, hey, do you drink a lot? Do you use tobacco or smoke any cigarette products? Or do you said no, but he does socially drink. And you guys can ask questions if it's okay, Nicole and Tim. If they have questions that are pertinent to the slides while we go, I am happy to try to field some of the clinical questions while we go, if it pertains to the slides.
Okay.
So when you also come to the hospital, he had his regular vitals checked, slightly elevated, 140 over 75. He had a heart rate of 78, so that was normal, and his temperature was normal. The doctor who assessed him at first did do a physical exam, and I also did that same exam when I saw him, and there was no tenderness. He was, like I said, a morbidly obese gentleman, so his belly was really big, but there was no fluid moving around in there, and no pain when I touched it. And then he had yellowing all over his skin. So the gentleman on that first cartoon, as you saw, was all yellow. This gentleman, every place that you could see was yellow. Even the sclera is the white in your eye. So all of that was very, very yellow. And then he had no hepatomegaly. So when I touched his belly, I couldn't feel that his liver or anything was large. And then I couldn't feel any huge lumps in his belly. So that was a quick introduction. So what I hope that you will gather from this presentation is we'll identify some of the key hepatic labs. Our hepatic means liver. And then we'll go over some possible liver pathology, so diseases of the liver. And then hopefully we'll have fun because I want you guys to ask questions, understand what's going on. And then I'm going to go over like a basic cartoon and anatomy of the liver and what the liver does, because the liver does a lot. And then lastly, I always want to create an environment that's safe and that you guys feel that you are learning and able to ask questions and have fun while doing it. All right, so this is my image of the liver. So the liver is a powerhouse. I'm not sure if everyone's familiar with the liver, but the liver itself does a whole lot for our body. So a lot of people like to call the liver, it's like a cleaning tool for our body, or one of the ways we clean our body out and all the toxins. A lot of medicines are metabolized in the liver. So oftentimes we'll tell a patient, hey, this can cause issues with your liver if you take too much. It helps with production of red blood cells. And the decompensation of it. So it breaks down the red blood cells that are old and we need to eliminate from our body. It regulates the blood cells as well. So you see blood cell composition. It also helps with our hormones. So it helps to produce them, but then I just mentioned that it also detoxifies the body. So it's a way to cleanse our body. It also helps with vitamins. So vitamins A, B, C. It really does like help to make those vitamins for our body. This is honing in on the toxin. It detoxifies, and then it produces bile that is excreted from our body that helps to break down some of the toxins. And then it helps. And I'm so sorry, I have a pet. If you guys heard that, he's joining in, and it helps with proteins and cholesterol. So our liver does a lot for our body. And so when things start to go wrong, we start to see issues. All right. So mentioned, we have liver enzymes. And so with that, the key liver enzymes are AST, ALT, ALP, and our bilirubin. And then I asked what other important lab work that we have. And so really, when we look at it, some people will get like a CBC we want to see. And so I'll tell you guys, because I didn't realize you didn't have the bubbles to talk to me in the chat. So we also look at like an INR, which is if the person is bleeding a lot and if they're clotting, because like I said, the liver helps with red blood cell production and composition. So his AST, ALT, ALP, and bilirubin, I will give you guys the answers. they were all very elevated. So these are not normal numbers. His were at least 3 times what they're supposed to be. Just now, we checked a CBC to make sure that his blood counts were normal, and they were, and then his kidneys were functioning normally. So no other organs seemed to be breaking down, but we knew something was wrong with his liver. I don't know if, I guess it's just the Q&A, so I will also tell you this. So something's wrong with his liver. When we went back, I'll go back a few slides. So this bile breaks down into a yellow color. So if you guys are starting to get the picture, something's wrong with his liver. It's overproducing this byproduct that should be excreted from your body. All right. Is there a way to, I know that is there a way to kind of answer or really quickly to say, I guess, well, we can keep going.
Yeah, there's no questions.
Yeah, I know, it's hard, okay. I know, it's okay. All right, so let's just look at the normal liver. So this is an MRI, and I wanted you guys to see what a normal liver looks like. So I hope you guys can see the outline. I tried to do an arrow. So this is the normal liver in the body. And the gallbladder that produces the bile sits under here. And then you have other stuff. So this is the spine. So if you're looking, this is the spine of a person, and the liver sits here. Okay. So this gentleman, and I had to scroll. So when you look at an MRI, I did a capture of a picture, so I couldn't get the entire thing. But this little circle here was blocking his liver vessels. And so all of the byproduct that should be excreted was being blocked by this. So this was a slide that was asking, what are some differential diagnoses? So if you imagine, I don't know if you guys ever watched any of the medical shows, Grey's Anatomy, and they're walking around the hospital, I would stop the residents and go, okay, guys, we only have pictures, we have labs. This is the time that Meredith Grey would say, what do you think is happening? Or house? And what do you think we should do? So this is called our differential diagnoses. So some of the things that we started thinking, and you put them in order. So unfortunately, cholangiocarcinoma, which carcinoma means cancer, hepatocellular carcinoma, which is another type of liver cancer. You have to ask, does he just have metastatic liver cancer? So did the cancer come from another primary site? And now it's in his liver causing this. Is it the gallbladder? So the little organ under the liver, is that what's causing all of this? Or is it pancreatic cancer? So the pancreas lives to the right of, to the left of the liver. And if the duct is blocked by that big mass, it could be blocking up the liver as well. So as physicians, we started having a conversation with the patient. We don't know what it is yet, but we have to run down all of these possibilities due to his presentation. All right, so I put that the first diagnosis was the most primary, and that's just because of his presentation. So it is in malignancy of the bile ducts. So within your liver, you have channels or vessels that come out of the liver that does excrete the bile. And so it was actually blocking on the image one of those ducts. So risk factors and why we consider this the primary diagnosis, he was 72, and this is more common at that stage of life. He had other risk factors if he had other chronic diseases for the liver. So we asked him if he drank alcohol or if he had any other damage, which he didn't, but those put you at greater risk. And then his presentation, because he had jaundice, fatigue, he actually didn't have weight loss, but he had decreased appetite. And then sometimes you do get that enlargement that you feel. His was just enlarged on image. So how do we confirm the diagnosis? So all of this right now, and this was a very tough conversation with the family, because even though as physicians, we can see things on imaging. It was a very, like, I went in the room multiple times with the patient, and this is an art that you guys will learn. And this is learned by doing, because no one gives you a manual on how to have hard conversations. And we call them at Christiana courageous conversations. And I think, like, dealing with patients' lives, they're always courageous because you put yourself in the shoes of the family members and the patient. But we have to biopsy it to actually get a diagnosis. And so although we suspected this, the positive, it could have really been a benign and not cancerous tumor. Everything was pointing that it was cancerous and it was not benign, but we could not say that for definitive purposes. So the diagnostic tool is to do a special MRI with a sample that is taken from the lesion. All right, so I went into the room and I explained to the family, we see this. The image shows that it's one size, but we'll have to do what's called a biopsy. So that can be done in multiple ways. Percutaneously, we try to not be invasive if possible. Are endoscopic. So the ways are you put a scope and you try to get a clip from the liver without having to open the person up. And with that, we get to stage it and say if there is any metastasis, meaning did it go to other parts of the body, or is it just localized to that one spot? And then it also helps determine what to do next, because most patients, they hear, I have cancer, now I need to figure out what's next. They don't hear all the in between, even if you tell them this may not be dangerous. So coming and telling them the treatment options. Some of those were surgical resection. Do you do chemotherapy or radiation? Or if it's not curable or resectable, do you start talking about palliative care and making the person as comfortable to enjoy the rest of their lives? So the prognosis and outcome for cholangiocarcinoma, so there's unfortunately in this gentleman a poor survival rate, especially if it's in the late stages of diagnosis. So along these lines, a lot like a pancreatic cancer, a lot of the liver cancers, as I mentioned before, the key word is painless. So we don't know how long this gentleman had this mass. It would have never, been found if he hadn't turned yellow, because that was his sign. He didn't think he needed to go to the doctor. He just thought he needed more rest for the fatigue. And so unfortunately, it's typically found in the later stages. And so the prognosis is poor because of that. The survival rates are by stage. And so the greater stage, 1 through 4, if they're at a stage 4, means that it probably has moved to other parts of the body. The survival rate is lower. And so importance of early detection and intervention. So you're probably asking the next question, well, how do we do this? He didn't feel anything. As a primary care physician, I would say shameless plug is to go to your doctor. And that's what primary care is here for. I know he was having worsening, he was feeling fatigued for more than the week. So it wasn't that he just felt fatigued for the week. He just thought he was tired. The jaundice did happen in the acute setting, but when you do feel sick, these are the moments to come to the primary care doctor to get worked up, and we would have done lab work, and it may have been a different outcome. So the discussion, and then we'll open up for question, the Q&A. So there's challenges in diagnosing this because it's similar to other liver diseases. So he presented, you could have a person who drinks alcohol and could have liver cirrhosis and is not cancerous and can have similar presentations. So that's the importance of the imaging and the biopsy. And then in this, I was the person that was the hospitalist or general medicine physician in this. But I would not have been able to diagnose him because if you remember what I mentioned, it was the biopsy. I don't do the biopsy. We need other surgeons to do that. And so it is very important to have the oncologist and our interventional radiologist team to do those things for us to help out and get those answers for the patient. So in summary, our case of the yellow man, he came with jaundice, he had fatigue, and he had elevated liver enzymes. And then we did see on his initial CT, it was a liver mass. We suspected that he had liver cancer, specifically cholangiocarcinoma. We managed it by doing a biopsy to definitively say what it was and to stage it so we can prepare for treatment. And then the prognosis depended on the stage. And so I ended my case with him at the stage where he was getting the biopsy. It was actually over a weekend, so his biopsy was not scheduled for Monday. I did check up on him because, true to my primary care self, I like to follow up on patients and just make sure. Unfortunately, he is back in the hospital. So I anticipate that they may not be able to resect it because it was similar numbers, similar scenarios. And so I'm assuming that they're going to try to do more palliative than resection. So they probably cannot take it out based on the size that was documented in the MRI. So that is my presentation. I want to leave time. I'll stop sharing, but if we can open up the Q&A, that would be awesome. And see what questions we have.
Alrighty, I don't think at this point there are any questions.
Oh, that can't be Tim.
It might take a little bit to type them in.
If you could stop sharing.
How do I? Okay, I thought I did. Let's see. Did it go away completely, or is it still my other screen?
Now it's just your other screen.
Your desktop, yeah.
How do I stop sharing, guys? Am I not?
I think there should be like a pop-up towards the top where it says stop sharing, or the little green share button.
The share button. Yeah, let's see.
Someone just said excellent presentation. Thank you.
Oh, well, thank you. Now you guys know I don't know technology, so that's also awesome.
Well, there you go. Questions are coming in now.
Tell you what, I'm sharing and.
Okay, good. Thanks, Tim.
Okay, now let me stop share, and that should, nope, now we're back to your desktop.
Oh, they're back to me. I'm not trying to take over, I promise.
Okay, well, if you want, I can start on questions.
Yeah, start on questions.
Okay. So, first question is, can a fatty liver diagnosis become cancerous?
So yes, in a small percentage, that's why we really do get concerned with fatty liver disease. So there are small percentages that can become cancerous, and they're not cholangiocarcinoma, but there's other liver cancers that can develop.
And then next one, can this be fixed, or will the man have this forever?
Yeah, so those are the options that the cancer doctor will talk to them about. So fixed is a different word. So if it was, depending on the size, they can take it all the way out. And so yes, that's saying I have no more cancer, it's fine. The size that his was probably the size of a little, like, I'll say a lemon. And so even though to us, like a lemon is very small, in your liver, that's an organ that's pretty large. And when it's surrounded by a bunch of blood vessels, it's actually really hard to remove that without causing a lot of bleeding or like damage to other organs. And so to fix it, you then have to choose options of making like laser, which is radiation, to try to shrink it and shrink the size, or giving medicine like chemotherapy, which will be like in your veins to try to shrink it and kill the cancer cells. So it just depends on what options they chose for his treatment.
And I guess this kind of follows up. Do you know if this might be for the oncologist, but do you know if he was given a certain time frame of treatment, or what the prognosis was, like his outcomes, how long he might have had? There was a question about
Yeah, and I didn't, so I left and I didn't follow up on that with him. When I briefly spoke, um, it was depending on the biopsy at the time that I spoke to him. So there was no like prognosis at that time, or like how long things would go.
Would a patient at this stage be eligible for a clinical trial, or is it depending on, would be?
Yeah, so I would say if there was some, I mean, it's always depending on the patient. So I think that that's some of the steps, and depending on like his health, like he was very healthy. So I anticipate like the oncologist, if there was a clinical trial out there, I think that, so two things. I think that they would have offered it, but then as a physician, our goal is to give everyone all the options. We are not ethically, we should not withhold any type of treatment. Now, with the caveat of saying we don't know if it'll work, but these are your options that we try not to do no harm. And so in that, doing no harm would be to not withhold anything that we could do for a patient to potentially help them.
Okay, great. And then I will kind of combine two questions. So how can liver cancer even develop? And I know probably part of that is genetics, but also, is there a way to prevent it with a healthy lifestyle, food, exercise? What are things that could help better someone's chances?
Yeah, so with this gentleman, it was very interesting after you, and I didn't put this part in. He actually had, so it was genetics for him. So he had like two family members and like a sister. So a very close family member that had liver cancer. And I want to say maybe his dad. So sometimes for genetics, there's nothing to do. I'll say with some cancers, like I'll use breast cancer, for example, when we know that it's in your family, one of the preventative ways is to get screened sooner. So that's one of the ways that we do it. For cancers like liver cancer, there are no routine like screening. So there is no, we come every year after age 45. However, when you go to the doctor and your doctor asks questions like, do you know anyone in your family that have cancers? This is the reason why we do ask these questions, so that we can make kind of the connection between that. So if there is the slightest, I don't know, abdominal pain, we go, oh, okay, well, maybe we should be looking at this in this particular person because they're at higher risk. Or when you go get your colonoscopy screening or whatever deals with GI, we would be looking more specifically for that. And then lifestyle, so some of the things like, of course, we know alcohol, that actually increases your risk. So limiting alcohol use, and then fatty liver disease. So limiting fatty diets, eating healthier, having that healthier lifestyle. All food groups, and I don't think any diet is a good diet. The word diet is probably not the best that we use in our society. So limiting in moderation in all food groups, because you need them all. You need sugar to fuel the brain.
Right.
So
But that doesn't mean you guys should have candy every day.
yeah, you cannot have candy every day, because then that leads to cavities and other
Right,
things.
exactly.
But
That's a whole other issue. Okay, and then what about jaundice in babies and young children? Does this happen?
So good question. So that is a little bit different. So so when we are born, as you know, maybe your body basically regulates your body while you're inside the womb. So once you're born, it takes time for your body to start waking up and all of your organs to work on their own. So the reason why little babies get jaundice is, if you remember that slide that said the liver helps to break down red blood cells, start them. So it also helps with our clotting factors. And so when we're first born, we don't, and I also said it helps with vitamins. One of the vitamins is vitamin K. So we don't have enough of that initially when we are born sometimes. And so with all of this like cascade of stuff happens, we need to get more of it. So the jaundice builds up because our little baby bodies cannot poop out all of the toxins fast enough because we are new to this earth. And there's a lot going on. There's all these new people trying to talk to you. There's all these new voices. You were just warm and cozy. And so now your body is an overload. So what we have to do is we do the photosynthesis light. I don't know if you guys have had little siblings or somebody else, and it helps to break down the jaundice. So very good question, but very different, same reason, but different reasons. Beginning of life, it's because your little body is really trying to keep up with the world. End of life is because something in like a bad thing is happening that's blocking the breakdown.
Oh, we also have another comment. Thank you. Super informative and excellent presentation. So we wanted to share that. So I had a question specific about the slide about liver enzymes. So what would be the normal levels of the liver enzymes and bilirubin? And how elevated were the patient, the yellowing man, in comparison to the average?
Yeah, and you guys are asking me hard questions because I don't know that right off my top of my
well, if you have a general
do you
idea.
have in your internal medicine brain what the like normal? I can't think right now what the normal. His were 3 times. They were like super high.
Okay, 3 times higher. Okay.
Yeah, they were like triple what they need to be. I do not have the normal. My brain isn't working right now, so I can look it up very quickly.
I think 3 times gives them a pretty good idea.
Okay. I was like, I don't have. I can Google it, but I don't. I don't have the normal numbers in my head. I'm
I
not
will
that good
second
at
that. It is, yeah, those values were very high, very eye-catching, and certainly correspond to the physical appearance of the patient. That's why he looked so yellow.
Yeah. And then I guess on this thing, can a fatty liver affect blood pressure?
So, yeah, no, not in the true traditional sense. I think oftentimes fatty liver disease, high blood pressure, or hypertension goes along with the whole person. So we typically see these in a person that's unhealthy altogether. So they have morbid obesity, because then they have a fatty liver. So it's not that it is not causation, it's associated. So it doesn't cause the other, but it truly does go together a lot in the patients that we see.
Oh, and then back to the family history genetics side of things. Should people who do not know their family history, whether due to adoption or other reasons, be more concerned about liver issues? Or I guess in general, should you be getting screened for these type of things?
Yeah, well, that's a good question. So again, there's no like standard screening, unfortunately, for liver diseases. However, I would say always on the guideline screenings for any cancer that we do have. So let's say it's cervical cancer or colonoscopies, colon cancer, mammograms for breast cancer. I would recommend that regardless of your family history, that you do them, because some cancers can be what's called spontaneous. So it doesn't have to happen because you know your family genetics. It's helpful to kind of go down that path and understand it, but it's not always associated with that. So I think getting screened, no matter if you do not know your family lineage. And then there's always genetic testing. It's not typically done unless there's a reason to do it. I know that now in the world and society, there's all these commercial companies. I would be very wary. Christiana in itself has a genetics group. So I would go through like your primary care. Once again, we are your primary home. You should always ask your doctor how to best, if that's something that you're concerned about because you don't know your history, I would go the route of going through my doctor and saying, hey, these are my concerns. Can I at least get genetic testing? Understanding that some of it isn't covered by your typical insurance, and that's a whole different conversation. It's not because it's not our typical screenings. But it is important to know.
And then, so in the case of the yelling man and people at an older age, is there a larger risk if they were to do chemotherapy or radiation treatment?
So that's a good question. So we have, it depends on the patient. So I can have a 72-year-old that has, I will say, uncontrolled diabetes or uncontrolled hypertension. They've already had 2 heart attacks and they've had a stroke, so they can't walk. Whereas I'll say this gentleman, like I said, yes, he had chronic conditions, but they were all very well controlled. He was retired, very active with his family, would go out and walk and, do all the physical activity things, despite his chronic diseases. So if you look at those 2 patients and when you go, that's what I said, we need the multidisciplinary team. When you go get assessed by the oncologist, they actually put you in risk categories. And they have those talks with you. They'll say, hey, I think that, the 72-year-old person who has had 2 strokes, cannot walk, has dementia, or whatever else, it's not really eating already for other reasons. They may not be able to withstand the chemotherapy. Maybe we think of other ways to treat them versus the person who is the 72-year-old that is vibrant and moving and still dancing 6 nights a week at line dance class. Their body may be stronger to handle it. So it really depends on the patient. So age, I will say, it does not take you out of the fight for your health. And I think that we look at every person in a unique manner. As physicians, we do not say, well, you're this age, you're not eligible anymore.
And then I think this might be the last question if no others pop up.
Okay.
Do you know any other diseases or deadly diseases that come with jaundice as a symptom?
So the one that is the most I guess common that we hear of is pancreatic cancer. And Sebastian, you can chime in. That's the one that comes to mind right now. And once again, I think that is I say deadly. It's because typically it's incidentally found and it's painless. So the person doesn't have any pain and they come in with jaundice. And that's our first sign that something's wrong before we get to detect it. And so I would say it's not the only thing that causes it, but something that is more dangerous, I would say pancreatic cancer.
I'd like to add there's a few other categories of conditions
Mhm.
or illnesses that can cause jaundice. Another big group is what we call hepatitis. Anytime you hear a word with itis at the end, it means an infection or inflammation. And hepatitis, and there's an alphabet soup of them. There's hepatitis A, there's hepatitis B, and there's hepatitis C. They're caused by different viruses. And scary as that sounds, the good news is we actually have vaccination for 2 of them. And we should be talking to our doctors and to our pediatricians if our children are under the age of 18, and or our family medicine doctors, whoever's taking care of us, about whether we are good candidates for those vaccines. Because if you do, as you know, get those vaccines at the right time of your life, you can actually avoid the risk of catching those infections because, as you just heard, in the worst case scenario, they can lead to pretty severe or lifelong illnesses or some very severe ones. There's another big clump of causes of liver jaundice and liver disease, and those are some toxins or drugs. And one very common one that causes very bad jaundice and liver failure sometimes when it's a very bad situation is Tylenol. Acetaminophen is the other name for Tylenol. Over ingestion. What that means is if someone accidentally takes too large of a dose. And it matters how old you are, and it matters how much you weigh. There are actually recommended doses you should not go over. And occasionally we see patients who accidentally have taken too much. The liver can't handle that big dose. They can also sometimes have jaundice. And the other big category of reasons people get jaundice is there's actually some blood disorders. The liver itself may not have a mass, but it's not doing its function well, the function of breaking down red blood cells, meaning there's so many red blood cells breaking down, it can't keep up. And then all the breakdown products have that yellowing color and it seeps out into the skin. And that's when patients come to us complaining of that yellow pigment that has made them look yellow, like Dr. Peters' patient that she described.
Right. I've got a question myself. So, especially in neonates, in the newborn, is there a racial skew to who's more likely to exhibit neonatal jaundice?
Mm. What do you
I
think, Dr. Peters?
so it tends to, I know it's like, oh, like I don't like some when I was in peds eons ago learning. So it would be a boy, and African American. However, I think those in data changes all the time. So I think those are a little outdated. I do see it in all races and all genders, and so I would not lean towards that there is one. And like I said, even from me, not being too far removed from medical school, data has changed even with what we call things because we are learning new things as we go along. So you may read some outdated sources that will lean towards one race and gender, but it can be across the board. And we treat every pediatric neonate the same. Like we do the same, we look at them and do the same counts per hours of life to make sure they don't have large amounts of jaundice in the neonate. So
This is not a genetic reason, and it is not linked to the baby's family heritage or background, but babies that are born prematurely,
right, yeah,
they are at slightly higher risk because they're born a little too early before their livers are ready
right.
to cope with
Yep.
being born.
Right. Another question from the queue, is it possible that a portion of the liver can be removed successfully and the remaining part will regenerate?
So the liver is one of the organs that we can do liver transplants, and they are technology for it heals and you're able to use that organ still. So yes, it is one of the organs that we can do that. But it also depends on the part of the liver. So that was like in this gentleman's case, it was entangled near his vessels, and so you can't really remove that portion. And that was you can't just like slice a piece of the liver off because it was near the vessels.
All righty. Would the jaundice be reversible for a patient who ingested too much Tylenol?
It is.
Yes, it is. If the situation is caught at the right time, early enough, there are medicines to reverse the toxicity. For the vast majority of patients, when they come to care, um, they'll be pretty critically ill for a little while, but we're very optimistic we're able to help almost all of them.
Right. And then Brianna asks a little bit different from jaundice or the liver, but from a different field. Is there any particular reason why pancreatic cancer is painless?
I don't know the pain receptors of the pancreatic cancer, but it's it's because of where it is in the organ itself. And it is into Boston. If you know the pain generation behind the pancreas, it typically just doesn't, because it's not, I don't know, it's awesome. I don't know the pain etiology or the pain morphology of the pancreas. It typically just does not cause.
Correct. And in its
Yeah.
earlier stages, it's not really surrounded by a nest of nerves. And that's why
Yeah.
usually to cause pain, a nerve or many nerves have to be compressed or pressed upon. And so just because of where it is in the body and what other organs are around it, or in this case, not around it, meaning not that many nerves.
Nestled. Yeah.
Yeah, it's more surrounded by blood vessels, exactly. And so in the earlier stages, it does not cause symptoms.
Yeah.
Well, and it's always been my impression that like hypertension, in the beginning stages, there tends to be very little symptom manifestation. However, when they progress to a certain point, then all of a sudden it can have very profound symptoms. Let's see. When I worked in postpartum, many of the Black children had to get light therapy for their abdominal bilirubin. I always wondered if bilirubin testing machine had a data bias. Good question.
So I don't think it does. Now so the good thing about that is most scales that we use, in medicine, we actually, like I said, medicine is changing and it's always changing. And so another example of that was our kidney GFR. It used to actually go by race. So there are new studies in showing that. So the machine does not. Looking at someone's, because it's the heel prick, and so it's blood. And so it shouldn't have a bias on how it's reading your blood, if that makes any sense. It's a blood test. It doesn't go through the skin. The lights do, but not the heel prick to check the baby's blood.
Right. And Gabriella asked a really deep question. How does cancer grow?
Oh, okay. So I love using analogies. And so cancer is a cell in our body that just passes a checkpoint and is not regulated. So imagine our lovely Delaware toll stations. So think about all the cars going, but none of them getting stopped, and they're just flying through the tolls. So in our bodies, all of our cells have checkpoints. Those checkpoints kind of go good cell, bad cell, good cell, bad cell. When it's a bad cell, it leaves our body and gets gobbled up, and our body eliminates it. And that's what our immune system does. What a cancer cell is able to do, it comes in and it's like, we are a huge Tonka truck. We're going to bypass the Delaware tolls. We don't care. We are now able to multiply for whatever reason. So if there's like a genetic reason, environmental reason, that this cell is able to morph and then bypass those body checkpoints, they then get to grow in that area, and then they're able to move along the body. And so I remember in bio thinking and having the same deep thought and saying, oh my gosh, any cell could technically go rogue and become cancer in my body. Thank God for my immune system, because that's what my immune system does. It looks at those cells and goes, this is a horrible cell. I'm going to gobble it up. It's not passing my checkpoints. So I hope that gave like a very like rudimentary explanation, but that's how cancer grows. So at any moment, a cell could be a great cell, and then it comes into some environmental or genetic point that changes to a bad cell, and your body just can't fight it off by itself.
Righty, well, it looks like there are no additional questions, so I want to thank you very much, Dr. Peters, Dr. Salam, always great to see you. Next week, we have 3 presenters talking about breaking through barriers, tackling medical complexities locally and globally. See you all next week. Bye-bye.